there's two types, and they are a little bit different in how they present. But we don't have to drill in super hard.
That's not on our PowerPoint.
Oh, that's probably because I took it out, because I didn't want y'all to get all, never mind, just, yeah, there you go.
Yes, it's just.
Well, PRI malformation might be on the test, but I literally just said I don't want you to get hung on this, so, okay. Take a breath, it's okay. What is PRI malformation? It's basically, we have this little bitty tag here at the bottom of the cerebellum called the vermis, and it usually is tucked up in the brain, and it doesn't do anything. And sometimes we have this little tail that kind of wants to come out here, and where our spinal cord exits the skull, that little tail wants to sit there too, and sometimes it gets squished and inflamed, and that causes problems, especially the more of the little tail there is. That's a very, Amanda's laughing at me. This used to be her.
Little tails.
It is kind of like a little tail. Anyhow, so that is essentially what it is. That is the malformation part. That little part should not be getting there, not be sitting there where it can get like tensed and inflamed and bothered. So only about 10% of them of one type kind of require any sort of immediate intervention in infancy. What we can see sometimes is that the infant will exhibit like a weak cry and have some stridor and apnea with their breathing. They get this, look at these random assortment of symptoms that can go along with GI disturbance, and that goes along with aspiration and choking and gagging and prolonged feeding times and weight loss and coarse upper airway sounds, diminished collapse and gag reflex. I mean, that's kind of like our breathing's weird, our digestion's weird, and then we're choking on it. And older kids might have upper extremity weakness and spasticity and headache. So again, kind of run the gamut on symptoms here. So anyhow, basically what I want you to know about this also is that a lot of times this is an incidental finding. There very well could be some of y'all in here with PRI malformation that you have zero idea about it because it's really not symptomatic for you. So it is not uncommon that we find this like maybe adolescence, because we did a CT or MRI based off of head trauma and we're trying to rule something out and we're like, also by the way, you have PRI malformation. And they're like, what is that? I didn't ever know about it. And so sometimes we have no symptoms, or it might even go a long time, years and years, without having symptoms, and we get to a point in our life, and then we begin having symptoms. So this one is kind of a weird one in that it's there from birth. The little tail can get more kind of inflamed or entrapped there with if there are certain other things going on. So sometimes something happens to make the symptoms that go along with it more pronounced. So it is kind of a weird one. It is. But the other component, I took out a lot on that. Okay. So if it is causing issues, there are different ways that it can be dealt with. We do have there are some that will kind of have like a decompression done to kind of help alleviate the pressure on that area. There have been some that have tried shunt placement to help with that, the pressure that would kind of push the tail down into that area more. And then there are some medications that have been used. It's kind of a hard one to manage, and it really depends on the individual symptomologies that are present. So that's what I want you to know about that. You've heard the name. Okay, hydrocephalus. This is also not a super common one. This is definitely something you'd see more in the hospital. We do have underlying disorders here that cause it, and it can be either congenital or acquired. So we can already have like a structural disorder that causes our brain not to either we're producing too much cerebrospinal fluid, or we're not recycling it, because your body recycles all of its components eventually. And so we have that collection. Or it could happen like if we're a preemie, that we have some bleeding on the brain at birth, and we can cause this. So it can be either congenital or acquired. And obviously there are grades of this as well. So the more fluid we have collecting here in that closed system, the more dramatic the symptoms would be, and the more concerned we would be about it. Anyone that has developed hydrocephalus, especially as a child, has a risk for damage to the brain from that extra pressure, and the longer it goes on and how much pressure there is. So if it is more prolonged and there is increased pressure, then we risk developmental delays, even visual, hearing loss, things like that. So this is typically more of a long-term care consideration. This is just the patho. I already told y'all about how the ventricles are the places where your CSF is made and then recycled. And so that's also happens to be an area, especially in the preemie population, that the vessels are extremely friable, and so if we have bleeding from whatever might happen in that premature birth and that phase of care, it tends to be into that area, and that's why those babies are more at risk for developing hydrocephalus as well. So the earlier we can identify that we're experiencing hydrocephalus, the earlier we can intervene. Because remember, if it's long-term, it might be bad enough that we even have like the splitting of those cranial sutures and like a really big fontanelles that are really like wide open and bulging, but that doesn't happen overnight. So of course, we're going to be looking for those early signs of increased intracranial pressure, especially on the infant side. This is where we might see some of those sunset eyes. You might hear that high-pitched cry. You might start seeing some of those dilated scalp veins, and then see some of those other physiological changes like the lower respirations and heart rates. So for this, we want to relieve that pressure, that extra pressure within the system, and then manage the complications from that. So most often this is also treated with a shunt, and here's where I'm in our shunt picture. So most often we will have a VP shunt, which stands for ventriculoperitoneal shunt. We can have a VA, ventricular atrial shunt, if they have like some sort of a GI. We have some kids that have like all the problems, and then they have GI surgeries and all that sort of stuff as well. We obviously don't want to shunt bringing them to an area that already has problems. So we really don't use that one very much in our pediatric population, but it's a possibility if we have like multi-things going on. So for a VP shunt, has anyone ever seen a VP shunt? Okay. So they're actually, this is what they look like before we surgically insert them. And like I said, we can use this with some other things as well. But they're this like flexible tubing, and the little kind of clear square part, there's actually magnets in there. So once we insert this surgically, we can, well not we, not you and I like bedside RNs, but whoever on the, like the neurosurgeon or, you know, someone with more credentials. They can actually adjust the flow of how quickly it's able to evacuate CSF. So the goal of it is it's implanted to help take extra CSF out. Obviously, we don't want all the CSF gone. It has to be a low and slow process. So they would start low and slow, and then they can kind of increase how quickly the flow is going or decrease it based on symptoms of what we're seeing outside. This is a baby that just had one implanted, and you can see it's kind of like it's tunneled under the skin. Eventually hair will cover that and you won't be able to see it. And it's actually pulled through on the other side, and they're, especially for our infants or younger kids when we put these in, extra is kind of coiled in the abdomen so that it can stretch and still stay, the end stays in place as they grow. If you get a VP shunt as an infant, it's very likely that you will have several shunt revisions in your life. If you haven't, a lot of them will have them for their whole life because tubing can get kinked, it can get clogged, especially if your CSF is high protein, all sorts of things. So the other component, obviously we worry about infection, right? But, oh, this is just a decompression. This is through a skull fracture, which technically could happen, but for our younger infants, we can actually do this through their open fontanelles. Did anyone get to see one of these in the NICU? It's a mildly disturbing to see them like put a butterfly into the fontanelle and drain off CSF straight there, and you're like, a little bit, but. So the point of that is, once we get them to a regular amount of CSF around their brain and spinal cord, then that's when they're going to have regular functioning, right? So we have to make sure that we have a good health history of present illness. We're looking for those early signs of increased intracranial pressure, which y'all already know, we already talked about them. And then we want to make sure that we're really managing, I want to skip to the bottom, for the shunt malfunction. So what would what would it look like if our shunt wasn't functioning correctly? Yeah, we would have those signs of increasing intracranial pressure, right? Because if the shunt is there to help maintain a balance of CSF that's appropriate, and all of a sudden it gets clogged or twisted and it's not able to, that pressure and that CSF is gonna build back up, right? So you just go right back to your little list of symptoms we already talked about with increasing intracranial pressure. So, anyhow, you already know that part, and then you just put that in there. So we have to make sure we teach parents and caregivers about that too, because we'll keep them while we keep the shunt and make sure it's healed and we have it set at a good rate, but we don't typically keep them forever. They'll be going home to be cared for by someone else. They have to also know those signs of shunt malfunction, which are the signs of early increasing intracranial pressure. Okay, y'all can tell I'm on the clock. Okay, craniosynostosis. This is when we have a premature closing of our cranial suture lines and fontanelles. So it's actually not very, very common, but the reason that we address it here is because it is found and addressed in young kids. This doesn't affect adults. They pass it. So it's a very good prognosis, but it is a surgical repair. So if we don't fix it, like this would be a skull that potentially has craniosynostosis. This is a normal one. It actually makes like a little cross. If we are missing some of our cranial suture lines, what do you think might happen?
No brain.
Yeah, your brain and your skull are not going to be able to grow appropriately to support what is needed for brain growth in that first year of life. So that would be bad. So we actually, if we find this, we have to go in, the surgeons will make a surgical incision to allow for that growth. So it is a surgical correction. Obviously, we would do, these babies are born with a normal head circumference, but then as they grow, and y'all know we see the infants all the time in that first year of life. So we would ideally find this within the first couple of months. Their head circumference is not going to track with the rest of their body growth. What will it look like? Yeah, it will be tracking smaller in comparison to their height and weight, or their length and weight. They're not at height. The other thing that sometimes we see, we want to make sure that we look at it from all sides, because sometimes it's not always like one suture or another that is missing. It can be either one or both. Like your book actually has multiple types of craniosynostosis, so don't get too in-depth. But sometimes that means that the growth can be a little disproportionate on one side or the other, depending on where the cranial suture is missing.
Maybe like an absence of fontanelle.
Yeah, so potentially, depending on what's missing, they might not have a good fontanelle, or it might be very, very small compared to what you expect for that age group. So that's why I can't say that yes, they would be absent, because it could be, you have different suture lines. So it depends on which one is already fused. Again, it could be all of them. So we would expect that we wouldn't feel probably normal fontanelles, and then we see that head growth. Since we do that head circumference every time, would be tracking low and falling off the chart. That's a good question. But again, since it is a surgical correction, our big thing is it's usually a stepwise surgery. So of course we worry about, the scalp is very vascular. We worry about bleeding internally too, because any bleeding that seeps into the brain could cause increasing intracranial pressure. Yes. We also worry about infection, because when we've opened up a surgical area right there to the brain, that would be the bad infection, right? We don't have any kind of protection from that. And then these kids will be wearing a helmet for a while to protect their head as they're healing and as that's growing appropriately. So lots of parental education and support, because after we do these surgeries, we have to be kind of careful with how we give pain medications. Why would that be?
We can't measure the level of consciousness.
Yeah, it's hard to measure level of consciousness or certain neuro responses appropriately if we have them snowed on pain meds, right? So we have to, it's a very fine line between keeping them comfortable and having a really good neuro assessment after these surgeries. So that's a nursing consideration for us. Okay, positional plagiocephaly. Y'all want to say it just because it's hilarious? Yeah, it's a good one. It's a good one. This is, the sutures are fine. but we have an asymmetrical head shape. And most often, it is because that baby likes to sleep on one side, and they're not, the grandmas are always like, we gotta keep rotating their head, smooth their head so it's a nice round head. Did any of y'all's grandmas when you say that to your kids? Okay, well, my grandma's special, I guess. But if they lay on one side over and over again, it's at one spot, again, their heads are very moldable. It's how they get out of the vaginal canal. It will make a flat spot. So for these kids, while we're assessing them, we have to make sure every time, not just these kids, but this is how we find it. You're not just looking at them face on, you also view them from around the sides and looking down on their head, because sometimes they look fine like this, and then you look at them from the back and you're like, that is a wonky shaped head. Sometimes if a child is experiencing torticollis, where one or the other side of the neck muscles is too short, then that keeps them in that position, and they can't change it. And so in that case, we would have to do some PT and stretching with the neck muscles to be able to help fix it. But mostly it's, a lot of times the kid likes to really sleep on one side, and maybe parents or caregivers don't really know better. Especially if they're using the car seat or the swing a lot instead of getting them up and holding them a lot, because they tend to lean their head on one side and then we'll start making their head. The technical term is cattywalker. It's not, that's not, don't actually put that in. The way we fix this, if it's just regular positional plagiocephaly and there's no torticollis involved, is that we do education. That infant needs supervised tummy time. We need to be up and being held. We need to be changing the position frequently. And they don't really need to be in the car seat unless they're going for a car ride. Or they don't need to be sitting in the swing all day long. Babies are made to be held and loved on. Sometimes if it's really bad enough, we'll have to do a molding helmet to get it back into shape. Okay, so we talked about that, viewing the head from different sides, assessing the range of motion in the neck to make sure that there is appropriate range of motion, and we don't need to do like a PT with that if there was torticollis involved. We will typically do a skull x-ray or a CT when we're first noticing this, just to make sure that all the cranial suture lines are there and appropriate, and rule out that it isn't actually our craniosynostosis. But once we have established that those cranial suture lines are fine, then we do the teaching and maybe the molding on that. Okay, infectious disorders, bacterial meningitis. So when we have an infection of the meninges around the brain and spinal cord, it is a medical emergency because it can kill you real fast. Can lead to brain damage, nerve damage, deafness, stroke, or death. One thing that has really reduced our incidence for this is, first of all, the Haemophilus influenza vaccine, the DIP vaccine. And then also most colleges require like the meningitis vaccine before people move on to college campuses, and different states require the meningitis vaccine as they move into like that 11, 12-year shot range. So being able to give that has really reduced our incidence of meningitis. So you don't have to memorize all this, but there are different organisms that can cause the infection. For example, like newborns, E. coli, passing through the vaginal canal, being right down in there. That is one of the most common causative organisms in that age group. So just so you know that there are different bacteria that can cause it, we still have the same result, and that's a bad infection. So since we have inflammation and swelling and exudates and tissue damage like right all up there on the brain and spinal cord, that's nasty. We don't want that. It can be secondary to, a bad enough, I cared for someone in the hospital one time who had a bad enough sinus infection that they developed bacterial meningitis. And oh my goodness, really bad ear infections. If we accidentally introduced bacteria doing an LP, if we didn't keep our sterile pills, or doing some sort of surgery. Trauma that's penetrating, if we crack your skull open and there's gravel in it, well, that's a possibility. So this can actually come from many bacteria and many incidents that introduce it. But it is a medical emergency. It does require hospitalization and treatment. We will do a lumbar puncture to establish what kind of bacteria is growing. We will do a blood culture and sensitivity as well. And after we've gotten our cultures, then we will start broad spectrum antibiotics, and then we will narrow it down depending on what our cultures come back as to make sure that we're treating that specific bacteria, since again it could mean many things. And then potentially, depending on what kind of swelling issues we have going on and what we're seeing there, we could also do corticosteroids to help reduce the swelling of the brain tissue. A lot of times this comes on very quickly. So the presenting signs and symptoms and recent medical history, they might have been like, Dad, Ethan, like went to bed feeling bad, had a cold, had a little bit of fever, and then can't literally get them up this morning. So it can be a really quick progression to where they're very, very sick. Our general appearance, we might see that opistotonic posturing here, which remember is the one like the fish out of water. We will see that nuchal rigidity is how we describe it, but that's where since the meninges are so inflamed, it's very sensitive for them to even turn their head. And this will be like, can you touch your chin to your chest? And they cannot, it is too painful. They will not be able to do that. Yeah, everyone's like, ugh. And decreased range, they'll be holding their head very still. They're not gonna be the one like you say something like, what? No, they would be like, oh my gosh. Bulging fontanelles, if they still have open fontanelles. Positive Hernick and Brudzinski signs, we'll look at that in just a second. And here you go, Alicia, here's that rash. That abrupt eruption of petechial, vesicular, or macular rash. So it can be full body, it typically starts on the trunk and neck, and it looks like the little burst blood vessels under the skin initially, and then typically those kind of start to coalesce and become, move from pinpoint to being larger areas of discoloration. So, again, sudden onset, there might have been a preceding kind of cold, flu, sort of viral infection type symptoms. Typically you have a presence of fever and chills, and that might be a pretty high fever. If they're old enough to complain of a headache, we would typically see that along with vomiting. What are those signs of? Early signs of increasing intracranial pressure, yes. Photophobia, what does that mean? Light sensitivity. So with those, it might even be like this level of light might be hurting their eyes. That stiff neck, that nuchal rigidity, maybe the rash. That rash is typically most often seen in the meningococcal bacteria, but it can be seen with other bacteria. Irritability, drowsiness, lethargy, muscle rigidity, seizures. Again, those are all signs of increasing intracranial pressure too. So in infants, they can be more subtle, as always, but they might have like poor sucking and feeding, a weak cry, lethargy, and vomiting, especially if we start seeing that rash or anything like that. That would be very serious. So here are examples of the Hernick and Brudzinski signs. So the Hernick sign, that's the one on the top. These kids, if we have their knee flexed up and then we try to extend the lower part of their leg, they will try to move their position because that extension is too much and it's making pressure on their inflamed meninges. And the same thing with that Brudzinski sign, if we're laying supine and we try to put that chin to neck, they'll typically kind of curl up their legs and knees to try to relieve that pressure, because those are, again, in a child, that should not be uncomfortable to do this, but that will be wildly uncomfortable for them, and they'll be in pain and pressure along their neck and their back. So that would be noted as a positive Hernick and Brudzinski sign if we see that reaction, that pain reaction, and that trying to accommodate by changing position in those. So again, we will draw a lumbar puncture, and we need to do a Coltrane sensitivity on it, our CBC, and our blood culture sensitivity. And then depending on how sick they are, they might need supportive ventilation. We probably will be on seizure precautions. We want to reduce that inflammatory response and get that infection under control. And if they are having seizure activity, we'll need to control that as well. The other thing is, this is a droplet transmitted disease process. So we do put them on droplet precautions, and that means as soon as we even suspect someone is in the ER and we're like, oh, this looks like meningitis, we don't have to have cultures back to confirm that. They are on isolation precautions. And that is because it is very, very transmissible, and it's a high rate of poor outcome. Okay, let's just say it that way. So, they will have to be on their droplet precautions until they've been on their broad spectrum antibiotic therapy for at least 24 hours. And that means also parents or close contacts that have been with this person prior to them being placed on protect or isolation, they will have to do prophylactic antibiotics because it's serious, and we want to make sure that they don't also develop. Okay, so here is kind of the reducing fever that we already talked about antipyretics, reducing environmental temp. Why do we want to avoid shivering? If we don't want them too hot, like in their environment, but why do we want to avoid shivering? Yeah, your body uses shivering to create heat, so you're working against yourself if you're trying to cool them down and they're creating heat. So that little top portion there can also go back with febrile seizures. So that's, but again, our meningitis, we talked about the droplets, post-exposure prophylaxis. Oh, and if they're around someone who hasn't been immunized for Hib or for meningitis, and they're one of their close contacts and it's age appropriate, then we would want to go ahead and get those immunizations up to date too if they've been in close contact. So ways to prevent bacterial meningitis: if they're a GBS positive woman, that is why we screen for that prior to delivery and go ahead and get antibiotics started on that mom. We do want to give the Hib and meningococcal vaccine as appropriate in their vaccine schedule to help decrease incidence. Okay, I think I have time to do aseptic meningitis real quick. I'm going to talk about the matchbox. Aseptic meningitis is actually the most common type of meningitis. So we just talked about bacterial meningitis, which means it's caused by bacteria. This one is usually viral. Okay, so it's nice that this one is actually the most common one because it's less severe. Now, initially they present with very similar symptoms, although we usually don't see the rash in aseptic meningitis, but they'll still have like the nuchal rigidity, the photophobia, they might have the headache, vomiting, those sorts of symptoms. So we put all of them on precautions first. We put all of them on the broad-spectrum antibiotic first, and once our labs come back and confirm for us that this is a viral cause and not bacterial, that's when we will switch our treatment plan. So once it is noted to be viral, they can come off their isolation precautions, even if it hasn't been 24 hours, because the antibiotics ain't doing squat for a viral infection, and then we switch to supportive care. So potentially, there are some that we could do with an antiviral medication, if they're like presenting really poorly, but if they're not like super sick, we'll just do like the IV fluid support and the monitoring and the seizure precautions. And a lot of times they will go on home after a few days, whereas the kids with bacterial meningitis might literally be in the hospital for a couple weeks recovering. So I guess if you had to pick one, you would want to pick this. Rye syndrome, so this one's quick. What do we worry about rye syndrome? I don't know. Aspirin. So I'm not going into rye syndrome. It is bad. It can easily lead to death. And this is why we don't give aspirin containing or salicylate containing products to children, especially if they have potentially experienced a viral illness. And y'all know kids, they could be having an active cold and just have a little runny nose and be running around fine. So it's real hard to know when a kid has had an active virus in their body when they haven't sometimes. So that's what the big takeaway. Now, what is the one time that I've told y'all this semester we do give aspirin as part of the treatment? I love y'all. Okay, Kawasaki with aspirin and IVI. But in general, we need to watch those. So we'll finish kind of hit on a few things. I feel like I still really needed to include it in peds though, because head trauma is one of the leading causes of childhood morbidity and mortality. So it's still important to our population. Obviously things like falls, motor vehicle accidents, pedestrian or bike accidents, and then of course child abuse are considerations for us here. And we already talked about how that larger head kind of affects their center of balance. So if they're going to fall, they tend to fall head first when they're younger. So obviously trauma can run the gamut from just very mild all the way up to life-threatening. And so there's a lot of differences in how someone might present with head trauma. So obviously our prognosis and our assessment and our interventions also depend on their particular case. But I do want to make sure, whatever it is, we need a detailed history about what happened around the incident And we wanna focus our initial exam on our airway, breathing, and circulation, right? And our neuro exam, as a baseline part of that is critical. So we wanna know how they're initially presenting, and that way we can make sure we are able to identify any changes from that initial baseline. Anytime we have had trauma, we do wanna stabilize the neck until we're sure that that trauma hasn't, affected any of like our cervical spine or anything like that. And so that might need imaging, so it might be x-rays, it might be CT, MRI. We do wanna make sure, and y'all have already talked about this, if we notice any sort of drainage from, like if we have a penetrating injury on the head, obviously, but the nose and the ears too, it could potentially be cerebral spinal fluid. And so don't forget, if it has, glucose in it, if we were to dipstick it, that would indicate cerebrospinal fluid. Also, when that sort of fluid drains onto a pillowcase or a 4x4 or anything like that, it tends to delineate the halo sign. Do y'all remember what that is?
The yellow.
Yeah, that little yellow kind of stained halo around the outside of the bloody part. So that would indicate a leakage of cerebrospinal fluid, which obviously would be very, very concerning for us. So a mild to moderate head injury. Now this happens a lot. What are something you could think of that actually is very common for a child to experience mild to moderate head injury, especially in school age and adolescence?
Falling off the monkey bars.
Oh, falling off the monkey, yeah, falls on the playground, yes. What about sports? Like concussions count in this category. So y'all know that's really, really common, especially for someone who plays a contact sport. But what we're looking at there is there's a brain injury without penetration to the skull. There wasn't loss of consciousness or other injury to the head or body, and then you're behaving pretty normally afterwards. So these guys are normally cared for at home, and usually also make a very full recovery. But we do want to be on the lookout for some things, because we know that sometimes even after mild to moderate head injury, we might not see changes right away. It might take a little bit of time for the problems to arise. So this is straight from your book, so I do want to make sure that y'all go back and look at this. But teaching guidelines, if we've had someone come in with that head trauma and we're going to release them, well then their caregiver needs to know what to be on the lookout for. So they need to make sure that someone who knows the child well is staying with the child for the first 24 hours. So this probably isn't the time for date night with a brand new babysitter, because they wouldn't know if the child is being weird, different, or otherwise, right? We do still want to wake the child every couple of hours while they're sleeping to make sure they're still easily rousable, and that once we do wake them, that they're conscious appropriately to their age. So, when we do that with adults, we'd be like, what day is it? What's your name? Who's the president? Those sorts of things. Obviously, kids are probably not going to be able to answer some of those depending on how old they are. So it would be like, again, you just have to adjust it for age. And then we do want to continue to closely monitor for a few days after that. So we want them to come back to a medical provider if they are seeing things like a constant headache that is getting worse, the child's continuing to complain about, slurred speech, dizziness, extreme irritability, vomiting more than 2 times, difficulty waking. Again, what are those signs of?
Intracranial pressure.
Increasing intracranial pressure, because we could have a slow bleed collecting, we could have swelling from the injury in the brain tissue. So those are the things we're looking for. Okay, so with a severe head injury, obviously this is when we've had some unconsciousness, maybe even all the way up to a prolonged comatose state after a head trauma. And those typically are our intensive care kids. So again, this isn't very different from what y'all discussed in critical care. So we want to focus on ABCs, stabilizing any other injuries that we might see along with this, evaluate that initial neurostatus so we can monitor changes from that baseline. And then we want to monitor for increasing intracranial pressure, and we want to go ahead and establish seizure precautions so that we have that in place and that safety in place. So for those, again, maintaining a nice, quiet, and dimly lit environment with lower stimuli, making sure that we're administering the meds appropriately and on time, and if they have something for sedation, that we're using that appropriately. Monitoring for that changes in levels of consciousness and other complications. So, now we're talking about non-accidental head trauma, and this would be head trauma from abuse. So this is a leading cause of traumatic death and morbidity during infancy, unfortunately. And again, we talked about that large head size and that underdeveloped muscles in the cervical neck area. So they're very much, and they have a floppy head, they just can't support it anyhow. So that, the average victim of this is under 9 months. I'm not gonna play the video, it's just an illustration of when a baby is shaken, the actual brain, the problems occur because we have impacts at the back of the skull where the brain kind of sloshes into the back, and then again at the front of the skull where you shake the other way and it sloshes towards the front of the skull. And so that can cause swelling and bleeding on both areas of the brain. And it can actually cause shearing force where some of those friable vessels that we talked about in the younger kids, again, do become bleeding. So now we have increasing intracranial pressure from bleeding and from swelling. And so that's where the problems with shaken baby syndrome, that's kind of pathophysiology of it. A lot of times this is unidentified. If it's not severe, how do you know if someone is shaking their child at home, right? Or if there's not some other outside picture that goes along with that. So when we are suspecting this, we need a very detailed history and physical, and especially paying attention to the caregiver's explanation of any injuries the child might have. And then if there's more than one explanation coming at you, do they match up and do they make sense? Because sometimes saying like, the baby rolled off the couch, okay, that's unfortunate, babies roll, probably should have been left unattended on the couch, but that happens. But then they have like 3 broken toes and a broken femur, and sometimes things don't match up, and then there's cigarette burn, all the things. It could be terrible, things. So that is one indicator, really paying attention to how this supposedly happened, and then if that makes sense to us as the person providing care. Also, if there's previous injuries. So while children do get bumps and bruises, and frankly broken bones are a very typical part of growing up, there are certain kinds of fractures that are more likely to be seen in child abuse than others. I really don't expect a very young child that's not walking yet, to have bruises all over them. So how are they getting bruises, right? Now it's different if you're a toddler learning to walk and your knees and elbows are skinned up and bruised, that's expected. But would you expect them to be bruised all up and down their back and butt? No. So just kind of making sure that, again, what we know about child development, and since this is our last class, you'll now know a lot about it, does it make sense with what we're seeing there? So sometimes bruising is present when we see shaken babies. Most often the bruising that we see is around the arms or around the rib cage, which makes sense because that's where they're holding them. Also, those are kind of weird areas to bruise just accidentally. That's not a fall down bruise. And another thing when we actually do an ophthalmologic exam is that with shaken babies, we'll frequently see retinal hemorrhages in the back of the eyes, like the back of the optic disc. This is not something you see just by looking at them. But that's from the pressure and from the coup contra coup force, which is what they call it. So that's very rarely seen in accidents, like if someone punches you in the eye or, things happen. So that is an indicator for us. That's not really something that, while that's in your scope of practice, I fully know most of you don't have a scope to pull out and look in people's eyes. So that might be indicative of where you work, but just know that that is something we, as a team, would be looking for if that was our suspicions. So we would do a CT or MRI to establish what kind of bleeding and swelling is present. We would do that ophthalmologic exam looking for retinal hemorrhages. And why do you think we would do a skeletal survey? Yeah, if there are other fractures in other places, and especially if there are other fractures in different stages of healing, why would that be important? Yeah, so that would typically indicate that this has been something that didn't just happen once. It was kind of, going on under the radar for a while. But it's very easy for this to also look like accidental trauma, and that's why we do have to be cautious and be aware if we have our suspicions, that we do a good job making sure that we follow up on that. Y'all know that you as nurses are mandated reporters, so also if that is your strong concern or you're seeing those factors, then you have to follow your area's policy on how that reporting occurs. There are some risk factors generally associated with shaken baby syndrome. This by no means means that everybody in these categories are going to do that. Obviously you know that. But the things that tend to increase a parent's stress level are the things that might accidentally I mean, there are plenty of incidences where it was just like a one-time kind of outburst thing, which obviously would still have really bad consequences. I'm not condoning it. But it's not always like a pattern of abuse. Sometimes it is a single stressor and they lost a little bit. So you can see things like being a single parent or young parent, if there's substance abuse going on by the parents, if that child is very sick or very needy medically, that can be high stress. So those are sorts of things that we want to make sure that those parents have good support systems and they don't feel like they get to this point. Okay, just a little bit on near drowning, and again, I felt like I couldn't take this out because it's the second leading cause of unintentional injury in our young kids under 14. And our registers for near drowning are toddlers who are mobile enough to get near water but not mobile enough to get themselves out, and then males, especially adolescent males, who tend to be more risk takers. We call it near drowning when they had a submersion injury but they survived at least 24 hours. And so obviously, what's the brain injury from a near drowning? Yeah, so we have a time period, whatever it might be, where the brain is not getting appropriate oxygenation, so it's an anoxic injury. And then how does your body respond to that?
Can't do anything.
Huh?
Can't do anything without your brain.
Well, you can't do anything without your brain, but as soon as we do start introducing, I should have been more specific, as soon as we start introducing oxygen to the body again, like we've done CPR, we reestablish breathing, your body's process is to then rush blood and oxygen to the brain because it knows it has to sustain the brain. Your body can't do anything without it. And so then on the other side of that, if we've rushed a bunch of blood and oxygen up there, yes, so we'll have that responsive swelling and that increases intracranial pressure. So it's really two injuries. That absence of oxygen is the first one, and then typically that swelling comes after it. And we have to be cognizant of both of those. So obviously, when we've experienced a near drowning, the initial component is the resuscitation and stabilization. Then we need a history of the event, and that intensive care frequently will involve some oxygenation management, whether that might be a ventilator, just depends on how long they were under and how severely they were impacted. But the other component of this, especially and very frequently, they have inhaled some water. Is that water supposed to be in your lungs?
No.
So what is that setting them up for?
Pneumonia.
Pneumonia as well. Now that is going to be the secondary picture in our clinical picture, because that won't develop right away, but that's going to be setting up to happen. So we also already know that, and we'll be monitoring for those signs and symptoms of pneumonia setting in, and again, that won't happen right away, but within a couple of days, we'll start seeing those changes in their chest x-ray. Okay, chronic disorders, so headaches. Headaches and migraines actually are very common in children, and for some reason, I hear all the time people are like, what do you have a headache about? And you just want to be like, did I need a reason? So it can be a lot of things. So it could be from eye strain. People who have a lot of allergies and sinus problems, especially with changes in weather, they will experience, headaches. One of our most popular, or not most popular, one of our most common groups that we see start experiencing migraine headaches in the pediatric population, what do you think it is? Yeah, that's a good one. Actually, post-concussion, there are a lot of headaches associated with that potentially, but females going through their hormonal changes when they're entering adolescence is one of the biggest populations that we'll say that we see in the pediatric population experiencing migraine-type headaches. Because y'all know hormones play havoc with your body. It's lovely of all those other changes, and they get migraines on top of it. But we do want to make sure that we're evaluating for the normal things, like is there a sinusitis or allergy, are there any dental issues, because like impacted teeth along the top can also cause, headaches, radiating headaches. Eye strain, make sure they've had an eye exam. But sometimes it really just is headaches, and sometimes it can be migraines, so then we have to manage those. So we also want to make sure that when it is just headaches and migraines, that we have appropriate education. Because most people, especially those who experience migraines, can identify in their history, they can identify triggers that really tend to either make their migraines more frequent or make them worse. And so some of that, like keeping a daily journal or when they're like feeling one coming on, making sure they're noting down what's been going on, whether it's weather, food, stress, lack of sleep, they've been sick, any of those things, so that you can kind of start tracking and identify their personal triggers. So some potential, like the headache triggers, y'all are probably very aware of this. I think a lot of this is common sense. But also there's a lot of foods, especially for migraine sufferers, that have components like the MSG and a lot of Asian style foods. Some people are very sensitive to those. Also some like perfume smells, certain dyes in foods can affect some people. So our biggest thing once we've decided, obviously we have lots of medications that can treat just general headaches or even migraine specific medications. But letting them know that kind of tracking what seems to trigger them can be very helpful and maybe they can avoid. Okay,